on now to our next speaker. Perhaps while they're coming up, we could come back to this in our discussion at the end, the role of consortia collaboration such as this in the sector.
Thank you. Thank you, Matthew. Yes, the bad things also bring so much of good initiatives. Like COVID came, and we didn't like it. The time was so difficult, but Umang and the team came up with the idea of forming this consortium so that we could do something nice. Thank you, Umang. Now I would like to invite Sergio from Peak Vision, who is going to talk on an innovative approaches to improve the services. Thank you, Sergio. Thank you. Oops.
Good morning, everyone. I will be presenting an innovative approach to rapidly testing service improvements to increase equity in care, which is based on socio-demographic characteristics of the participants. This work is part of a awarded, funded by the Wellcome Trust and the National Institute for Health and Care Research, led by the London School of Hygienic and Tropical Medicine and Professor Andrew Bastauros as a principal investigator, and I will be presenting on his behalf. This research has been conducted in 4 countries, India, Botswana, Kenya, and Nepal, and this data is around our program in Kenya. The first step is to put in place something that we all in the sector are aware. Access to services is unequal. There is always people who has better access to services everywhere, and that's true especially in low and middle income countries. There is a lot of evidence around that. For example, this popular research where a widow woman from rural areas were having less access to cataract surgical in Nigeria and Sri Lanka, and there are plenty of similar examples. So this is rooted in the Sustainable Development Goals and is aimed to leave no one behind and reach the farthest first. So this research is trying to be practical and suggest an option to make that a reality. So the approach is based on fair access, mainly with equity, community engagement, and robust scientific evidence as guiding principles. Is based in 4 stages, 4 steps. The first one being find those that require access. Data from this research is part of a wider project on big programs supported by CVM in 7 counties in Kenya that has been running for more than 2 years and screened more than 4 million people. So in this stage of finding, we have developed a module where, in addition to the basic information as age, gender, we are able to collect socio-demographic characteristics like occupation, marital status, education level, ethnicity, etc. So those identified with a need and being referred for services are also identified with their socio-demographic characteristics. We can then analyze the attendance to the next point of referral, and particularly in this case, we'll be focusing in understanding who are those, that 54% that did not attend. So in the next phase, which is analyze, we are able to understand who are the groups that are less likely to attend. This might be very context specific. In this case, where young males that are working in unskilled manual works, those that presented lowest attendance rates. So the next step, the target group where we want to intervene to improve their attendance, is understanding exactly what the barriers are, and that is just basically talking to them through deep interviews in what are their life experiences, the problems they face when attending, what could be changed for them to attend, to make easier for them to attend, so that produce a long list of potential barriers also, as well as possible interventions that could be conducted. Next is to then, in a phone survey, try to rank those interventions from 0 to 3 on those that could be higher impact. So we have a good idea of a number of interventions that could be tested. And finally, a group of stakeholders, including representatives of this population group, decide what is more feasible to test in terms of risk, cost, and potential impact. In this case, the interventions, the package of interventions that were decided to put in place was two interventions. One of them was improving the SMS reminder, making the text more appealing, more informative, increasing the frequency of SMS being sent, as well as improving counseling. So particularly for this population group, explaining where are the closing and opening times of the services, what services are available, and the importance for them to attend. Once that is decided, the software is able now to randomly distribute participants into arms, the control arm, which is the current practice, and the intervention arm that will include the enhanced SMS as well as the improved counseling. The algorithm will run for some time and will stop once there is a significant difference between both arms. Very surprisingly, we could see just after 14 days, the intervention arm was showing an improvement of 20 percentage points, respective of the previous situation, and having higher attendance compared to the control arm. So this is the fantastic outcome of the intervention, and it's also quite inspiring because there are multiple interventions that actually can be tested. This feature is now built into big software, so anyone can actually analyze the sociodemographic characteristics of those left behind and reduce the need for complex resources as statisticians that are not always available. In terms of lessons learned, I guess the flexibility of implementers that are sensible to do an extra effort for equity. They are not just looking to numbers of people coming, but understanding that those that are less likely to attend require an extra effort, and they are open to do that. And the balance of input, so the expert opinion as well as the community feedback is both equally important. So yeah, that's the main topics I wanted to share with you. Thank you.
Thank you, Sergio. Thank you. He was better than Umang, time-wise. So what I've learned is they were, like when they found that the men who did not have the work were the ones who did not attend the services, but they went back to them and then called them so that they engaged the community, they engaged the people who needed the services. What are their problems because of which they didn't attend. And I like the idea that we have to engage the people. We have to engage so that it is one of the things the WHO might have thought when they came up with this integrated people-centered eye care. So thank you so much, Sergio. And so floor is open for 2 short questions, please. Tulsi. Yes, Sergio.
Quick question. I think this is a very chronic problem for
Yeah.
everyone, this lack of compliance.
Yeah.
So you have huge data. So I was just wondering, as you are examining a patient at home, whether you can actually predict whether this person would be a complier or a non-complier. I think it might be possible because then it gives an opportunity for strengthening the referral. Otherwise, you would just say you go to the center and we don't say anything else. But if you know this guy is unlikely to go, then you could strengthen that referral process.
Yeah,
So whether we can use AI for this prediction. Yeah, that's a fundamental question. Yeah.
Yes, that's an excellent suggestion, and that's definitely something that we aspire to understand fully how that can be used. At the moment, requires the ability, the data is available. Contexts are very different in many countries, so requires the willingness to stop for a moment, take the data, analyze who is left behind, thinking about what to do, a number of steps. But it's true that the likelihood of attendance can be predicted somehow when it's enough data available. What is not so easy is understand what can be changed for those that are presenting less attendance rates for that to change. That will require always a bit of a qualitative, quantitative analysis. But that's true.
Anything else? Yes, Michael. Yeah.
Thank you, Sergio. Maybe to you, but maybe the audience. So I just have a question in my head that if we think that perhaps we'll never reach 100% uptake, what number is good enough on program level?
That's a very good one. I think we can only compare to our own context. So the first step, in my opinion, would be what is the overall average of attendance? That represents the context. Maybe it could be 50%. But then you can explore exactly which are the population groups that are having maybe just 15% of attendance. And there is a lot of interventions you can put in place to improve that 14 up to the average at least. And in that process of continuous improvement, focusing on the left behind groups, your average attendance will improve finally. But it's probably every context is different. So the average is a good starting point.
Thank you.
Thank you.
Sergio. I think we all have to go to Jivi's lecture from yesterday. We have to start small, and the small things make a big difference. Thanks so much. Thank you.